Hello, my name is Jordan Lee Slowick, and today we're going to be talking about malrotation and volvulus in newborns and pediatrics. Thanks for tuning in. Let's first review our learning outcomes for today. Number 1, identify the differences between normal intestinal anatomy versus a patient born with intestinal malrotation. Number 2, recognize the significance of a bilious emesis in a newborn or pediatric patient. Number 3, apply post-operative nursing knowledge to the care of a newborn or a pediatric patient born with malrotation and volvulus. And number 4, discuss the importance of patient advocacy and nursing intuition. Let's first review intestinal anatomy. The small intestine is made up of 3 segments, which form a passage from your stomach to your large intestine. The opening between your stomach and the small intestine is known as the pylorus. The duodenum is the short section of the part of the small intestine that takes in semi-digested food from your stomach through the pylorus and continues the digestion process. The duodenum uses bile from your gallbladder, liver, and pancreas to help digest food. The jejunum is the middle section of the small intestine that carries food rapidly through with wave-like muscle contractions towards the ileum. The ileum is the last section and the longest part of your small intestine. The ileum is where most of the nutrients from your food are absorbed before emptying into the large intestine. The purpose of the large intestine is to absorb water, salts, and get rid of any products that are left over. What is mainly left is fiber, which is a plant material that takes a long time to digest. Additionally, there are dead skin cells that are shed from the lining of your intestine, salt, bile pigments, and water. In the large intestine, bacteria feed on this mixture. This helpful bacteria produce valuable vitamins that are absorbed into your blood, and they can also help digest fiber. The large intestine is made up of the following parts: the cecum, the colon, and then the colon is made up into the following parts: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. The rectum is the final section of the digestive tract. Leftover waste collects here and expands in the rectum until one feels the urge to empty the bowels. The bowel movement is then emptied through the anus. Intestinal malrotation typically affects both the small and large intestine. Sometimes only the small intestine or only the large intestine is affected. Most people don't know they have intestinal malrotation until they begin to experience complications. In utero, the digestive system begins as a straight tube. At 5 weeks gestation, the tube starts to develop into the esophagus, stomach, small intestine, and large intestine. During this time, the part of the digestive tract that will become the intestine moves out of the abdomen and into the umbilical cord. For most babies, as the intestine forms, it re-enters the abdomen, making 2 separate turns, and then lands in the typical position by 12 weeks gestation. If an error occurs at any time during this normal rotation process, it can cause the intestine to be positioned incorrectly within the abdomen. This is known as intestinal malrotation. How common is intestinal malrotation? The exact incidence of intestinal malrotation is unknown. Birth-to-text surveillance data indicates that symptomatic intestinal malrotation affects between 2 and 3 out of every 10,000 babies in the United States, or about 1 in 4,000 babies each year. However, there is a 40% chance of those affected by intestinal malrotation that they are diagnosed after age 1, meaning the rate of symptomatic intestinal malrotation is more like 1 in 2,300. Many sources state that there is some degree of intestinal malrotation that may affect as many as 1 in 500 people. This is based in a very small study from 1934 and does not indicate what percentage of participants experience symptoms or complications. The unique position of the digestive tract in intestinal malrotation allows the intestine to twist upon itself. This is known as a volvulus. A volvulus is a type of intestinal obstruction that cuts off arterial and venous blood supply to the intestine. A volvulus is a dangerous complication of intestinal malrotation. Once a volvulus has occurred, the intestine has minutes to hours before necrosis of the intestine begins. Therefore, a volvulus is a surgical emergency. Let's talk about a key sign that a volvulus has occurred. A bilious emesis is reported in 80% of pediatric patients with a volvulus. Vomiting bile should be considered intestinal malrotation and volvulus until proven otherwise. Other signs and symptoms related to vomiting include vomiting undigested formula, breast milk, or food if older, projectile vomiting, large amounts of vomit. The parent may even state the baby threw up the whole feeding. The pictures you see are of a bilious emesis from the same patient. The patient's mother stated the emesis was projectile in nature. A 7-pound, 9-ounce baby who was 6 days old would projectile vomit 6 to 7 feet across the room. Picture A's emesis is neon yellow. You can see that the undigested bile salts are mixed with white formula, creating a yellow color. In picture B, the emesis is dark like ground pale. The bile salts had nothing to mix with, leading to the dark green color. Another sign that a volvulus has occurred would be changes in bowel movement. The patient may have absent or decreased bowel movements or sounds. The patient may also have painful bowel movements. If the patient is a baby, the baby may appear to be straining, grunting, breath holding from pain. When a baby breath holds, it is very scary. They can turn red or even blue. The patient may also have diarrhea, dark brown, black, or bloody stools, and the inability to pass gas. In the picture you will see a patient that was 7 days old with amber-colored urine. He was extremely dehydrated from his volvulus. And then in arrow B, you'll see that there's blood within the stool, and this stool was created by a glycerin suppository. Other signs and symptoms that a volvulus has occurred include abdominal distension, abdominal wall erythema, abdominal pain that can be consistent or intermittent, mild to severe, and can be often hard to distinguish in babies and young children. The child may also be refusing to eat or have a lack of appetite. They may be lethargic or fatigued. They may excessively cry or be inconsolable. Because fluid and nutrients are absorbed in the intestine, dehydration and electrolyte balances may occur very rapidly in a person whose intestines are blocked by a volvulus. You may also see dark urine, amber-colored urine, sunken fontanelles, sunken orbital sockets, as well as decreased urine output. You also may see signs of an infectious process like fever or elevated white blood cells. So why is a volvulus a medical emergency? A volvulus can restrict venous and arterial blood flow, which causes necrosis to the intestine. The intestines are highly vascular. Once blood is cut off, death to the bowel will quickly occur if not emergently corrected. Volvulus can also cause perforation of the bowel, leading to sepsis. A volvulus is a surgical emergency. If anything, please remember that. In the picture, you'll see an infant with a necrotic bowel from a midgut volvulus. The bowels are typically nice and pink, but in this picture you can see they are dark and brown, which means that they have become necrotic. How do we diagnose a patient with malrotation and volvulus? Patient presentation. The initial abdominal exam may be completely normal, luring the practitioner into dismissing the diagnosis, which unfortunately may lead to progressive bowel ischemia, hypovolemic shock, and possibly death. To diagnose intestinal malrotation with volvulus, an upper GI series, also known as a barium swallow, is most frequently ordered. It is about 95% accurate in diagnosing intestinal malrotation with volvulus. Other tests include a lower GI series, also known as a barium enema, a CT scan, or an ultrasound. In the picture, you'll see a patient who had intestinal malrotation with a volvulus, and you can see the corkscrew appearance of the duodenum. Treatment for intestinal malrotation and volvulus includes the LADS procedure. A LADS procedure does not place the intestine in the correct anatomical position. The goal of the LADS procedure is to untwist a volvulus and place the small and large intestine in a position that makes them less likely to twist in the future. An appendectomy is always conducted during the LADS procedure. Why do you think that would be? Let's talk about post-operative nursing care for a patient post-LADS procedure. First, we'd want to monitor the fluid status. Is the patient on fluids? Are they on TPN? How long have they been on fluids or TPN? And is those fluids going at an appropriate rate? Also, we would want to monitor fluid output. We'd want to make sure that the baby is urinating, and we'd want to make sure that we're measuring diapers accurately. We'd also want to see if the baby is stooling. Also, all babies or patients post-LADS procedure will have an NG tube to decompress the belly. We want to make sure that we monitor the color and the output of that material. We also want to monitor the skin, making sure the incision site is clean, dry, and intact. In regards to bowel assessment, it takes a little bit for the belly to actually wake up. We want to make sure that we reassure our families and parents that this does take a little time, and that even though it's stressful that baby cannot eat for a few days, it is well worth the wait, waiting for that belly to wake up. We also want to make sure that the patient has LADS. We want to make sure that the electrolytes are getting back into balance. And lastly, we want to make sure we support our parents and the patient. This is a very stressful time for families, and they need all the support and love that we can give them. Complications of malrotation and volvulus include necrotic bowel or questionable perfusion of the bowel. Additionally, short bowel syndrome. Short bowel syndrome is another potential complication of intestinal malrotation. Short bowel syndrome can occur as the result of a volvulus. During the volvulus, when the blood supply is cut off to the intestine dies within a few short hours. Any part of the intestine that has died must be removed, and if 50% of the bowel remains after surgery, the person is then considered to have short bowel syndrome. Additionally, if the bowel has become necrotic or has questionable perfusion, fecal diversion may be initiated, such as a colostomy. In the future, patients with malrotation and volvulus have an increased chance of adhesive small bowel obstruction, in which adhesive bonds and bands occlude the actual intestine itself. And unfortunately, the worst part about this is that death can occur if, unfortunately, the bowel is not able to be recovered. A typical presentation in older children or adults may include acute abdominal pain, intermittent bilious emesis, chronic and vague abdominal discomfort, nausea, diarrhea, malabsorption syndrome, and other less common characteristics would include bloating, constipation, GI bleeds, feeding intolerance, and failure to thrive. Let's talk about trusting your gut and patient advocacy and nursing intuition. First, let's talk about Maya. Maya Brown was born January 15, 2018, and passed away February 15, 2018. Maya's medical symptoms were missed by 23 medical professionals. She had a bilious emesis in which no medical professional she encountered knew was an issue. In regards to Oakley's story, Oakley was a baby boy born in a hospital. He was healthy and happy, and right before patient discharge, he had a green bilious emesis. Nurse Jen brought the bilious emesis to the pediatrician at the hospital, in which he informed Nurse Jen that the bilious emesis should not be an issue. Nurse Jen felt so uneasy about the situation that she actually went across the hospital to a neonatologist and showed him the blanket. The neonatologist came down, assessed the baby, and realized immediately that the patient had a volvulus. The patient was sent to surgery, and a life was saved because of Nurse Jen. Who do you want to be like? Do you want to be like the 23 medical professionals who didn't stand up for what made them feel uncomfortable? Or would you want to be like Nurse Jen, who stood up for what she believed even though it went against what a doctor said? For homework, you will be completing a reflective journal on what you just learned. I would like you to specifically focus on the stories of Nurse Jen and baby Maya. I'd like you to go to the Intestinal Malrotation Foundation and find the stories of baby Oakley and baby Maya, where you can read exactly how the parents felt during those situations. In the reflective journal, I want you to cover how the stories of Nurse Jen and baby Maya impacted you, and in what ways Nurse Jen was an advocate for her patient. And also, as a future nurse, how you respond to your nursing intuition if a situation, and when a situation like this does arise. For more information on malrotation and volvulus, please refer to the Intestinal Malrotation Foundation, which is www.intestinalmalrotation.com/information.